Hi everyone, my name's Simrat. I'm from Clinician Link.AI, where we're trying to revolutionize medical education. I have with me Dr. Wykoff. Dr. Wykoff, you just presented on the Aflibercept 8 milligram study, the 96-week results. Can you give us a quick kind of summary about what the results were?
Simrat, great to be here with you. Thanks for including me in this. Now, this is an important trial. We've known that 8 milligram Aflibercept is coming for many years, and this is the pivotal trial that led to FDA approval of the medication, which is now commercially available in the U.S. For DME. So Photon was a 2-year trial. The primary endpoint was at 1 year, and briefly there were 3 arms. Patients were randomized in a 1 to 2 to 1 pattern, center-involved DME with vision loss, into the 2Q8 arm, which is the traditional global standard 2 milligram Aflibercept, 5 monthly doses, then every other month through the 2-year endpoint. And then there were 2 8 milligram arms. So they were both fixed dosing after 3 monthly loading doses, either every 12 weeks or every 16 weeks. Again, the entire population was randomized, either 12 weeks or 16 weeks on the 8 milligram arms. And then in those arms, they had the opportunity in both years 1 and year 2 to have a reduction in their interval. So importantly, a lot of patients could go 12 months or 12 weeks and 16 weeks, but some patients, if you have too much fluid or you're losing vision, then you had to come down. And the shortest you could go in the trial was 8 weeks. And that happened if you lost more than 10 letters and there was an increase of 50 microns on your fluid status. And then during the second year, if patients were doing well and had no DME based on their OCT criteria and had not lost vision, meaning 5 letters, then you could actually be extended beyond your randomized interval to a maximum of 24 weeks. So that was the structure.
That's fantastic. And I think we're now looking more and more at studies, and there's that durability that's being built in, and it's kind of expected almost. So with these results, like, what are your thoughts on durability and pushing that for your own patients in your practice?
Yeah, the results here are important because the objective of this trial was really to push the envelope. And I think we saw that. I think we actually got to that envelope. Like a lot of times, I think that some trials, no drug in particular in my mind right now, but some trials may be designed as sort of a game to be like, look, we're going to prove durability. And this trial is also a little bit of a game because the control arm does not have the opportunity to be extended. But within that game, I think the design was actually sound because we were pretty aggressive on the visual acuity, right? Nobody in clinic wants to let patients lose 10 letters.
Yeah.
I would venture to say no one does that in clinical practice. And yet that was the design that was baked in because you have to quantify these things in practice in a clinical trial. So with that and pushing the envelope on 16 weeks to still achieve non-inferiority on visual acuity outcomes of both 1 and 2 years between both 8 milligram arms, I think was meaningful. But what I mean by achieving that pushing the envelope is when you look at the anatomic outcomes. And we did see some slight differences there between the every 16 week and every 12 weeks. And these are meaningful clinically. So most importantly on the OCT, right? When you look at OCT drying, you see that the 8Q12, 8 milligrams every 12 weeks, or the 2Q8 had similar OCT fluctuations after the loading doses, but the 8Q16 arm had greater OCT fluctuations that you could clearly see. So while we can conclude that on average as a population, the 8Q16 population could achieve non-inferior visual acuity gains, some patients based on OCT probably could have been dosed a little more frequently and maintained a drier retina, which is really sort of my take home for my patients when I manage this, which is to do what we're already doing, which is to individualize therapy. Some people need more, some people need less. And my feeling is that hopefully this medication as it's used more broadly will simply be an incremental benefit where patients will be able to go longer than they would have been if they had been on 2 milligrams and we're now transitioning to 8 milligrams.
Yeah, and you mentioned the anatomical outcomes, and Professor Monk mentioned this about volumetric analysis as well. Do you think that's something that should be adopted into clinical trials, or should we, because CST hasn't always been related that closely or correlated that well with VA. Is volumetric the way to go moving forward?
Yeah, it's fascinating. I mean, a lot of these trials have very specific numbers that we focus on. Numbers of letters gained or lost, numbers of microns of fluid. So for example, in this trial, if you had gained 49 microns, you would not have been, dose regimen change. Whereas if it had gone up 51 microns and lost the same amount of vision, then you would have been dose regimen modified. And so I think in clinical practice, it's more of a subjective evaluation of fluid for most of us. Some of us use CST. It's certainly a relevant number, but But overall, we kind of look at fluid balance. We look at fluid location. We look at visual acuity. There's a lot of factors that drive treatment initiation in DME and then how frequently you treat after that. I think overall, I'm a treat to dry physician, but I think that there is a future where we have more sophisticated software on our OCT machines that allow us real-time fluid quantification. So we know pathologic intraretinal fluid, pathologic subretinal fluid, and even layer segmentation to see the health of the photoreceptors, et cetera, that will guide treatment frequency and even maybe medication selection. So I think there's a future that Dr. Monk and many others are creating that's exciting. I don't think we're quite there yet in clinical practice.
Fantastic. Thank you so much for speaking with us. And thank you everyone for tuning in.